I'll just show you the slides which I updated. This is one diagnosis of influenza.
I think the live streaming has
With
started, Manohar. I think the live streaming has started. So
okay. I'll just start sharing.
Yeah, Manoharji, go ahead.
This is one diagnosis of influenza.
I think we can begin now.
Yeah. Good evening, everyone, and welcome to today's webinar on what's new in flu, current challenges and management options. For this webinar today, we have with us our guest speaker, and I would like to take a moment to introduce him. So today we have with us Dr. Sitesh Roy. Dr. Sitesh Roy is a US board certified allergist, immunologist, and asthma specialist. He is a founder of Dr. Roy Health Solutions Clinic, Mumbai. Dr. Sitesh Roy is an ex-associate professor of pediatrics and medicine and director, Jackson Medical Mall Allergy Immunology Clinic, USA 2002 to 2010. He has done the fellowship in allergy and immunology at National Jewish Medical and Research Center of University of Colorado School of Medicine, Denver, voted the #1 respiratory hospital in the US for 16 years in a row. Dr. Sitesh Roy is a fellow of the American Academy of Pediatrics, the American Academy of Allergy, Asthma and Immunology, and the American College of Allergy, Asthma and Immunology. He is a diplomat of American Board of Allergy and Immunology, Conjoint Pediatric and Internal Medicine Board, and listed among the best doctors in America. Dr. Sitesh Roy is the author of original articles and publications for leading medical journals internationally, and the first textbook chapter on stress and allergic diseases in Psycho Neuroimmunology textbook 4th edition. In addition to that, Dr. Sitesh Roy is also a TEDx speaker, allergist, clinical immunologist, asthma specialist, and trusted holistic healing specialist. With this introductory note, I'll request Dr. Roy to carry forward.
Thank you very much, Mr. Manohar.
Yeah.
For the kind introduction and a very warm welcome to all my physician colleagues in the eastern part of India. Warm welcome, and today what we are talking about is influenza. Can we have the first slide, please? So we're talking about what's new in influenza, and the focus here is going to be on figuring out the challenges and what the management options are for this condition. Next slide, please. So besides the challenges and understanding of flu, what are its complications? What is the evidence for Oseltamivir, which has been around since a long time, and the guideline recommendations for the empiric use of Oseltamivir, which will make our life easier and that for patients also easier. We all know that the H3N2, which is an influenza type A, has been causing a spate of high fever and cough. Sometimes this cough can linger for weeks after the person has recovered. Cold waves, fogs, rising pollution have also led to surges in seasonal flu cases. And we know that amongst the seasonal flu cases, we've also had a good bit of swine flu that has occurred, which is the H1N1 variant of the influenza A. Private hospitals seeing flu screening as number of COVID admissions rise in Kolkata. Very important thing that showed up comorbidity between two viruses affecting a single person, COVID with influenza. And also the differentiation between influenza and COVID getting harder. Testing sometimes becomes important, which we'll discuss. Next slide. So flu is not really a seasonal condition. It is perennially there in human circulation. So in any part of the world at any given time in the year, a few cases of influenza will still keep occurring, but there are spikes in these cases, and these spikes are usually seen in the monsoon of sometime after the monsoons begin, and then again in the winter months for whatever those months might be. H3N2 typically causing symptoms like high fever, cough, but also breathlessness and pneumonia in up to 27 and 16% patients. And when we look at the symptoms of wheezing, throat irritation, runny nose, breathing difficulties, we know that pollution and other non-infectious triggers, including allergic triggers, can sometimes cause these symptoms if you remove the fever part. So it really makes the entire picture fairly tricky sometimes to diagnose. And kids can continue to have symptoms for a prolonged period of time. We also find that the common perception that flu is a short-lived illness, it's better in 2 or 3 days, is not holding true with the flu that we are seeing now. And people suffer for a week, 2 weeks, and sometimes the post-viral cough can continue for months. Next slide. So we've already heard about the symptoms, body ache. Added to that, stomach flu symptoms like vomiting, diarrhea can occur, many times sore throat, and this makes it very hard to differentiate from the recent variants of Omicron, XBB 1.16 and XBB 1.5 and 1.9, which are co-circulating with the flu in the past month or two, and really becomes a tricky situation. Next slide. When an update on the seasonal influenza was taken, this is between Jan and March of this year, we can see that with each progressive week, the H1N1 cases were steadily there. The H3N2, which is the influenza A spike, was there, and influenza B was also simultaneously running steady. And these cases actually started to increase based on the surveillance work that is done by the ICMR, National Institute of Virology, Pune, along with its 27 other virus research and diagnosis labs across the country. This is a gross underestimation, as you can imagine, because this does not catch all the possible cases that are there. Clearly, these cases increase as testing increases, and we know that not everyone tests for influenza when they have a cold, cough, fever, body ache. Next slide. Healthcare challenges. Influenza-like illness, that is ILI for short form, the H3N2, which is the influenza A, the COVID-19, and then something called severe acute respiratory illness, which we know again can be caused by multiple viruses, including COVID-19 and influenza, but can also be caused by respiratory syncytial virus, which is RSV. It can be caused by adenovirus sometimes. It can be caused by parainfluenza virus. So there's a lot going on that we have to be, as healthcare professionals, be prepared to manage in the best possible way. Next slide. The dynamics of the occurrence of influenza. This is a 7-year cumulative study done in the Department of Virology and King's Institute of Preventive Medicine and Research in Chennai. And 36,000 samples, duration of study 7 years. Peak positivity, as was mentioned, starts with the onset of monsoon, peaks with the post-monsoon months. And this is one peak. As I said, there's a second peak that occurs in areas where there is a winter. And we certainly see it even in a place like Mumbai, and certainly northern India sees it to a much greater extent where it gets quite cold. Next slide. When you look at these cases, you realize that over the last 4 years in this study, or this surveillance data, 2015 to 2019, the number of cases kept increasing. They almost went up 6 times between 2015 to 2019. The deaths due to influenza went up almost 4-fold in that same time. Next slide. Influenza is one of the most common infectious diseases. We know this. In 1918 to 1920, the last major pandemic, which was called the Spanish flu, though it began actually in the United States of America, it was still labeled the Spanish flu because Spanish soldiers came down with it very heavily when they were in contact with American soldiers, and eventually it spread to the whole world, took 5 crore lives. Okay, that's 500 lakh deaths across the world. And out of that, 1.7 crore deaths were in India. This is 1918 to 1920. Fast forward to 2022-23, every year about 5 lakh deaths still occurring due to influenza across the globe. Okay, It's seasonal, but it has, as I said, perennial presence, mild to severe cases. Outcomes can even be hospitalization and death. Next slide. Influenza A commonly causes the epidemics. It varies by antigenic drift. Drift is a slow progressive mutation that occurs in the virus. This is a single-stranded RNA virus, so changes are very common. With every replication, there could be changes and error in the copy that comes. And out of these come the very, very vicious variants, which can give local epidemics. And when there is a major shift in the antigens of the virus, which means a big portion of the virus changes, generally in the hemagglutinin and the neuraminidase sections, which are the binding proteins of the virus, we can see a pandemic occur. And generally, it's been observed that an influenza pandemic occurs once in every 7 to 10 years, which is fairly frequent when you look at it. Influenza B infects only humans, causes only local epidemics. Influenza C generally is a mild infection and it affects humans and swine. Currently, we have the H1N1 of the influenza type A, which is a swine flu, and the H3N2 influenza A, which are widely circulating and causing people to be sick. Next slide. Can we have the next slide, please? Hello, Manohar, are you there? Can we have the next slide? Okay. When we look at the transmission of flu virus, people with flu can spread it to others up to 6 feet. Classic with what we call a droplet infection, also known as an airborne infection, sneezing, coughing, talking, singing. The same things that spread COVID-19 can also spread the flu. These can land on the mouth and nose directly to be inhaled into the lung. They can also lie on the conjunctiva. From the conjunctiva, they can make their way into the body also. Uh, Remember that while these are largely droplet-borne infections, if someone coughed into food and the food was consumed, then it's possible to transmit. So there are multiple ways. You touch a surface and then someone touches it and touches their eyes, nose, mouth. They can spread it. Most healthy adults are sick 1 day before the symptoms begin, up to 5 days after becoming sick. Kids can pass it on for much longer, 7 days or longer sometimes. So we have to remember that these infections are they have what we call an asymptomatic transmission phase before the symptoms begin. And then once the symptoms begin, 5 to 7 days, it can very much transmit. Next slide. Differentiating influenza-like illness, the H3N2, which is influenza A, the severe acute respiratory infection, and COVID-19. As you can see, fever, muscle pain or body ache, cough, fatigue, lack of energy, sore throat can be present in all of these. Okay. Breathlessness may or may not be present in the influenza-like illness, because if rhinovirus is making someone sick, that's the common cold virus, you won't get breathlessness in those cases. But a person gets rhinovirus and they also have asthma with it, they can become sick enough with their asthma that they can be breathless. So remember, these are very, very tricky pictures, and having an astute observation about the patient's general history, what their underlying diseases, comorbidities are, can be very helpful. Loss of smell and taste only present in COVID-19. But add to this someone who gets a bad nasal blockage because of their infection, they may also lose their smell. And if you lose smell, you can lose taste with it. So, but generally it's COVID-19 that does it. The common now variants, Omicron variants, don't do it as much as the Delta and the earlier Alpha Beta variants did. Diarrhea only in COVID-19, but I would say I have seen diarrhea in influenza also. So nausea, vomiting, diarrhea can be present in, that's what we call sometimes as a stomach flu. Headache may or may not be present in ILI. It's present in pretty much all the others. COVID-19, it says sometime in the current Omicron waves, but the earlier waves, headache is to be a very prominent symptom, and severe acute respiratory infection affecting the lungs, causing hospitalization may not have an associated headache, but it may have been present earlier in the disease. Next slide. Emergency or warning signs of flu. You need to know when to take a case of flu and either admit them to the hospital or to the ICU. So in children, fast breathing, trouble breathing, bluish skin, that's cyanosis. Not drinking enough fluids, not waking up or interacting, that's a bad sign. It means they're getting severely dehydrated or having neuropsychiatric complications. Being very irritable, that's also a sign of all of the above, including neuropsychiatric problems, which does occur as a complication of flu. Symptoms return, improving and then returning with fever and worse cough, can sometimes be a secondary bacterial infection that's occurring. Fever with a rash, this can again indicate many different things. In addition to the above signs, if there's an infant who's not eating, having trouble breathing, not having tears when they cry, much fewer diapers, this is all significant. More than 10% body weight dehydration, which is moderate to severe dehydration, needs hospitalization and care. In adults, the difficulty breathing, shortness of breath, the pain and pressure in the chest or abdomen, sudden dizziness, confusion, severe persistent vomiting, flu-like symptoms that improve and then worsen and return with fever, again secondary bacterial infection, are all emergency warning signs of flu. Next slide. Complications can range from a simple ear infection to sinusitis, all the way to death. In between, there's bronchitis, there is pneumonia, there is ARDS, that's your including the cytokine syndromes, the cytokine storm syndromes leading to ARDS, the worsening of existing diseases like asthma and COPD. All of these become major issues, and ultimately, if someone goes into oxygen deprivation due to complications of flu or neuropsychiatric complications, that can even lead to death in some patients with severe acute respiratory infection. That's SARI. Next slide. When we look at the diagnosis of influenza, your symptoms are your main way to diagnose this disease. So high fever, headache, sore throat, myalgia, cough, rhinorrhea, fatigue, gastrointestinal symptoms. We spoke about all of this. This is the early phase. When it gets into the complication phase, you can have a lot more. Lab confirmation is possible through throat, nasopharyngeal and nasal secretions or tracheal aspirator washings. And direct antigen detection is possible. There are rapid antigen tests which have a sensitivity of around 40 to 50%. You can isolate the virus through culture. You can also detect it by RT-PCR, which is the most accurate, more than 90% accuracy for detecting influenza. Next slide. As I mentioned, the antigen detection 47 to 93% depending on the kit you're using for rapid detection. Rapid influenza 10 to 70%. The direct immunofluorescence assays are also pretty good, but they can't differentiate H1N1 from the other viruses. The RT-PCR can, and it is the gold standard test along with viral culture. Next slide. Management of influenza, the crux of what we are here to discuss. So treatment in most cases is largely supportive. Bed rest, good amount of fluids, preferably warm liquids, cough suppressants, antipyretics, and simple ones like paracetamol, non-steroidal anti-inflammatory drugs for fever and myalgia. Most patients recover in 3-4 days. However, the malaise, the fatigue, the body pain, the headache, the complications of the influenza, including cough, can be persistent for weeks. So targeting this disease and treating it, even if it is short-lived, becomes very, very important. Remember, nowadays we are seeing more and more people have prolonged influenza because the same comorbidities that made COVID worse make influenza worse also. Diabetes, hypertension, heart disease, chronic renal disease, chronic kidney, liver disease, chronic respiratory diseases like COPD, then ILD, interstitial lung disease, asthma. So remember that though the disease itself in an otherwise healthy individual may last 3-4 days, the disease itself can lead to a lot of problems, and some people take much longer to recover. IV hydration and hospitalization may be required in some cases. Next slide. Treatment with antiviral drugs, the neuraminidase inhibitors, which block the NA enzyme, which is critical for releasing virons from the host's infected cells. So one cell gets infected, it makes millions of copies, then it has to release the virons. So another 100,000 of cells can get infected, and NA inhibitors affect that or stop that. They are active in influenza A and B. Oseltamivir and zanamivir are the classic Drugs, oseltamivir, remember, has been around since 1999, its first approval in the United States for treatment of influenza. Adamantanes, which are the M2 ion channel blockers, these interfere with hydrogen ion channel activity of influenza A, so it works only against the influenza A viruses. Amantadine and rimantadine are the two classic drugs. Next slide. Next slide, please. Antiviral therapy with oseltamivir. It's a selective inhibitor of neuraminidase enzyme of influenza A and B. It's a prodrug. It's converted to oseltamivir carboxylate in the liver. It inhibits influenza virus replication. Because it stops the replication, it doesn't let it pathogenically affect more cells, more organs, more systems. Hence, shorter duration of disease, less spread to others, and reduction in risk of complications. It is affecting against both influenza A and B, as I said, avian flu, which is H5N1, swine flu, which is H1N1, H3N2, which is what we are seeing now, and the H9N2 strains of influenza A and B are affected. Next slide. The mechanism, you can see the neuraminidase cleaves the receptor so that the budding virus can then come out and the viron can be released, and this can go and affect other cells. Now, if you block the neuraminidase, then the viron cannot bind to the necessary receptors, it can't be released, so viral replication and spread is halted. Next slide. It's been approved in over 100 countries, as I said, across the globe. Next slide. It was the first oral neuraminidase inhibitor. The typical dosing in adults, 75 milligram capsule taken twice daily for treatment for 5 days. When you're doing chemoprophylaxis, so someone who's been exposed and can get infected, you want to prevent the infection before it starts. So like a chemoprophylaxis dose at 75 milligram once daily for 10 days. As you can see in the different weight groups of children, 15 to 23, 23 to 40, and more than 40, it becomes like an adult dose. There is a syrup available in India, Fluvir, both in capsule and syrup form. And this can be conveniently dosed twice daily for infected patients, once daily for chemoprophylaxis or prevention in an exposed patient, especially a high-risk patient. And its approval is down to 2-week-old children. So you can imagine that the drug has to have a certain level of safety for FDAs across the world to approve it down to 2-week-old infants. Next slide. Best results are within 48 hours of initiation of the onset of symptoms, but remember, we'll talk about even longer and later introduction helping. So as you can see, the 30 milligram in the syrup formulation, twice daily, prophylaxis, 30 milligram once daily, dose convenience, no wastage, pocket friendly, cost is very reasonable for the treatment. Next slide with Fluvir. Contraindications are also important to understand. So there is if someone has an allergic reaction to oseltamivir or any component of the product, that becomes a contraindication for using it for them in the future. This is a serious hypersensitivity, not a simple little rash or something. Severe allergic reactions have included anaphylaxis and things like Stevens-Johnson syndrome, toxic epidermal necrolysis. So these have to be watched for. Erythema multiforme tends to be not a severe manifestation, but can become severe and hence becomes a relative contraindication for this condition, for the use of this drug. Certainly someone who's had any neuropsychiatric complications due to previous use of oseltamivir also should not have this drug given to them. Next slide. Oseltamivir is generally well tolerated. Only 5 to 10% patients may experience some spontaneous side effects that resolve in 1 or 2 days. Diarrhea, bronchitis, abdominal pain, dizziness, headache, nausea would be added to this. The list becomes long when you even look at a simple drug. Oseltamivir is very well tolerated generally. No serious drug-related events in clinical trials. Post-clinical trials, as I mentioned, neuropsychiatric side effects is something that had come up. It does require observation. It does require careful monitoring, and patients who develop any of these do need to be evaluated carefully to figure out why it's happening. Is it due to the flu itself that has affected the brain, or a complication of the flu that's affected the brain, or is it drug-related? Next slide. Benefits of empiric use and early use of oseltamivir. We'll look at some clinical trials. Next slide. This is a classic case of a 50-year-old patient, a farmer by occupation living in Srinagar, comes to a tertiary care center with uh, symptoms that he's had low-grade fever, sore throat, myalgia for 7 days, denying any chest pain, breathlessness, orthopnea, vomiting, diarrhea. Before referral had been given injections, ceftriaxone twice, levofloxacin for a couple of days, wasn't improving. Next slide. His vitals were a little heart rate that was up, which can occur due to the low grade fever he had. BP was normal, chest examination, bronchial breathing, some post bilateral crackles in the inframammary area. CPK and LDH were high, which we know can occur in any lower respiratory tract infection. Mid-zone infiltrates on the chest X-ray, nasopharyngeal swab was rightly taken. PCR showed H1N1 infection. CRP was not very high, 10, 5 and lower is normal, so a mild elevation. Cardiovascular, abdominal, CNS were all normal. Next slide. That's the chest X-ray, which shows the mid-zone interstitial infiltrates, which are classically seen in a lot of different viral infections, definitely in influenza. And so the PCR is the way to confirm what's going on with this patient. Next slide. PCR generally done for both COVID and influenza in today's day and age. One could even do multiplex testing for longer, for more viruses if the availability, the cost, and the affordability is there for the patient. This patient was started on oseltamivir 75 twice daily for 5 days, given some paracetamol, oral hydration, careful hand washing. Patient was isolated. He showed marked improvement in symptoms with progressive decrease in CPK and LDH. Subsidence of the chest X-ray infiltrates, as you can see on this X-ray here, the infiltrates have reduced significantly. And compared with the previous situation where there were a lot of infiltrates, here the patient is clearly improving. Next slide. So when we look at oseltamivir for influenza related illness, the decrease in antibiotic use, this is 3,500 subjects aged 13 to 97, influenza-like illness, enrolled in 10 placebo-controlled double-blinded trials. Oseltamivir was tried to see if it reduces problems. Antibiotic use reduced by 26%. Lower respiratory tract complications that would end up requiring antibiotic reduced by 55%, and hospitalization reduced by 59%. So all of these indicate that early use of oseltamivir or timely use of oseltamivir is rather what I would say does make a big difference, not just to the patient, but also to the healthcare system, because one patient coming in repeatedly to the doctor or going into the hospital, getting admitted, potentially requiring an ICU bed, and then the cost involved both to the system and the patient and family is immense. So timely and early use of oseltamivir, even if it might be empiric at times, is worthwhile. Next slide. Reducing occurrence and severity of pneumonia due to H1N1, that's your swine flu with early oseltamivir. Retrospective chart review, 442 patients, medium onset of symptoms 5 days. So remember, we look at differentiation between those who got their medicine oseltamivir started within 2 days or started within 3 to 7 days, 8 to 14 days, and more than 14 days. And we look at what was the occurrence and severity of pneumonia in these 4 groups who had different time points where the oseltamivir was started. Next slide. And what we can see here is the probability of severe pneumonia when we cross the 10-day mark starts rising very, very significantly. And in the first 10 days, if the drug is initiated, both the severity of the pneumonia and the probability of severe pneumonia gradually decrease. So earlier initiation of oseltamivir after onset of symptoms during the H1N1 pandemic of 2009 clearly showed a benefit. Remember, the drug was released in 1999. We had a drug available during the swine flu pandemic of 2009. So this was a study done at that time. And starting it within 48 hours of onset of symptoms showed considerable potential for reducing pneumonia. So if you say, let's wait for 3-4 days, this disease will get better on its own, you're actually missing a very critical window to start the treatment, which can make a big difference for your patients, especially the ones who have comorbidities, high risk factors, or anything else. Next slide. and even for healthy individuals who may be living with such people, elderly people in the house, the younger family member gets it, worthwhile treating if, or considering treatment to protect the other persons. Patients with shorter time to oseltamivir were discharged earlier from the hospital. As you can see, group 1 who started the drug within the first 2 days, very early discharge. 3 to 7 days it was started, definitely better. 8 to 14 days, better than starting it more than 14 days or 2 weeks after the onset of symptoms. So test early, treat early, or empirically treat early if the right indications and the cases are there. Next slide. Oseltamivir with azithromycin, can it reduce secondary bacterial infection? Retrospective observational cohort, patients admitted to the hospital divided into two groups, one that got oseltamivir only and one that got oseltamivir plus azithromycin for at least 3 to 5 days. Both were for 3 to 5 days. Next slide. What do we find? The incidence of secondary bacterial infection in the oseltamivir plus azithromycin group was significantly lowered, 23% versus 2.4%. And incidence of respiratory support, whether it's just oxygen or even further requirement of BiPAP, CPAP, and the BiPAP, or pressure ventilation, or requiring interventions like intubation, the incidence reduced from 38 to 17.3. So clearly less secondary infection, less need for respiratory support. You have to be smart in whom you give azithromycin to and why you select that drug along with oseltamivir, depending on the patient's clinical scenario, comorbidities, past history, complications, etc. But they can be given together and they do work quite well, especially this being a hospitalized cohort. Next slide. Oseltamivir azithromycin reduces secondary bacterial infection, reducing hospital stay, reducing influenza symptom severity score. Next slide. So guideline recommendations, WHO recommendation, empiric treatment is strongly recommended. Start as soon as possible. Lab confirmation, if can be done, do. Even if you get a negative lab test, remember, if the nasopharyngeal swab wasn't taken right, you will miss the infection. We knew in COVID up to 30 to 40% infections were being missed. But if it's possible and it comes positive, you're clearly gonna treat in the right case scenario. And if it's not, be still positive about using empiric treatment. People with higher risk, so as I said, people with comorbidities, the same comorbidities that we heard again and again with COVID, apply to the influenza cases also. Treat them and treat them early, even before the results come of their testing, if you've done it, if it's going to take time. Next slide. Early empiric therapy, according to the Indian Ministry of Health and Family Welfare, Directorate General Health Services, giving empiric antimicrobials to treat all likely pathogens causing severe acute respiratory infection, empiric antibiotic for community acquired pneumonia if it's in the healthcare setting, and empiric treatment with a neuraminidase inhibitor like oseltamivir, fluvir, for treatment of influenza when there is local circulation and other risk factors, or the patient has history of exposure to animal influenza viruses because of their profession or travel history. Next slide. Next slide, please. We went back. In adults with community-acquired pneumonia who test positive for influenza, should treatment regimen include antiviral therapy? We recommend it to be used. This is the American Thoracic Society. This was their recommendation quite early. It's been around for over 10 years. Anti-influenza treatment with oseltamivir should be prescribed to adults with community-acquired pneumonia, what you would call walking pneumonia, who test positive for influenza in the inpatient setting, independent of the duration of illness before treatment. So I've had chest physician colleagues who've told me that even day 9 or day 10, patient is admitted to the hospital ICU or even in the hospital ward with oxygen requirement, etc. They've started oseltamivir and seen benefits within 24 to 48 hours. So just because you didn't start it in the first 2, 3, 4 days, it doesn't mean you can't use it in the right scenario for others also. Oseltamivir is associated with reduced risk of death in patients hospitalized for community-acquired pneumonia who test positive for influenza. Treatment within 2 days of onset or hospitalization may result in best outcomes, although there may be benefits up to 4 or 5 days after symptoms begin. As I said, some people even suggest up to 9-10 days. And we saw in the earlier side where it was started between day 7 and 14. Also, there was a benefit that was noticed with earlier discharge from the hospital compared to people who had it started after 2 weeks. Next slide. So in summary, proper diagnosis can mean early treatment, can mean less complications of flu. Empiric treatment reduces lower respiratory tract complications and hospitalization and antibiotic need. Where the patient is hospitalized and the risk factors are there at those times, combining an antibiotic with oseltamivir can also make a big difference. WHO, ATS, and Ministry of Health and Family Welfare India recommend empiric use of oseltamivir in the right case scenario. Start oseltamivir therapy in every flu case that you feel deserves the treatment. Certainly, it's an area of question if a totally healthy, otherwise well individual catches the flu, has the classic flu, or caught the flu from someone who has the flu, do you treat them? Remember that influenza takes about 2 to 5,000 lives even today in America. And amongst those 2 to 5,000 lives in a country like America, there are totally healthy, normal individuals who die because of complications of the flu. So while I can't say that this should be used in every single case that gets diagnosed, I say you need to be quick to use it in the right scenario. And if you see any progression of the disease, even in a totally healthy adult with no complications or no risk factors, you should be quick to start it, preferably within the first 2 to 3 days, and if possible within the first 5 days. And with that, we shall conclude our presentation. We have some time, about 10 to 12 minutes. I thank you very much, all of you all, for giving your valuable time this evening and joining in on this webinar dealing with influenza. As I said, if you're looking at COVID-19 with influenza, certainly the RT-PCR test that can be done on a nasopharyngeal swab can look at both influenza and COVID-19 and help differentiate it. And in high risk patients, I would certainly, and I certainly do it even today in my practice in Mumbai, if I get a case where I feel that this person could benefit from right diagnosis and early treatment, I will do that, both of those tests together. Where it's not possible, I will weigh all the pros and cons and probably do the influenza testing and even start empiric influenza while I'm waiting for the results, to, empiric oseltamivir, till the results come back. So if there are any questions that you all would like to send in, I'll be happy to take them. I see that a couple of them have been forwarded already. Can fluvir be used along with an antibiotic? Absolutely can. Only in renally compromised patients, you have to recognize that oseltamivir up to 60% of the excretion is through the urinary tract. And people who have end-stage renal disease on dialysis can still take the drug. Dosage has to be adjusted. Please look at the package insert or the fluvir monograph that your pharmaceutical representatives can provide you. There's a lot of good information in that booklet. And according to the creatinine clearance being above 60, 30 to 60 or less than 30, doses can be adjusted. Do vaccinated patients also need antiviral treatment? Yes, if they catch the influenza. Remember, the vaccine efficacy is 40 to 70%. It is not 100%. And remember that virus through antigenic drift, which means from the time 6 months ago that the WHO released that the next vaccine has to contain these strains and the company started making it and you gave it to your patient, by then the virus has already gradually drifted. And because it's gradually drifted, even a person who's got the vaccine can get the infection. Do consider treating patients who get classic influenza or confirmed influenza with an antiviral drug, even if they've been vaccinated. How long can fluvir be prescribed? I said, there's really no upper limit to the time, but I try to use it within the first 3 to 5 days as much as possible. As family care physicians, general physicians, you may see the cases in the first 1 or 2 days, and with the right clinical acumen that you all have, and I'm very sure about it, you could start it within the first 48 hours if possible. Up to 10 days, as I said, it's shown benefit. Current COVID variant, how much fatality is it having? So the current Omicron variants, which I said is the XBB 0.1.16 and XBB 1.5, 1.9. These are all co-circulating. The fatality is much lower than what we saw in the Delta, Alpha and Beta variants or Gamma variants. Okay, I would say that the fatality rate all over India, we have much less reporting, much less surveillance now than we did before. But it seems to be probably, I would say, only the high risk individuals. So we know that perfectly healthy individuals also lost their lives in the previous waves. But in this one, it looks like it's largely the elderly, largely the ones with high comorbidity, high complications who are at risk for fatality. Healthy individuals, children are not typically who are otherwise healthy having fatalities. The rate, according to people, is 1/4 or even lower than what it used to be before. Um, Somewhere in, so if we look at 0.1%, 1% going into the less than 1% going into the ICU even in these times, I think we are not looking at a fatal virus. But do remember that Omicron also gives long COVID. So even after COVID, they can continue to have fatigue, brain fog, myalgia, breathing difficulties, other issues that may persist for weeks, months, and years. So we still can't take this lightly. Wearing a mask, both first for ourselves and then for our patients and their families, hand washing, hand sanitizing, maintaining distance, taking all the precautions is still important with the Omicron variants that are going on now. So please do take care of yourselves, because if you're well, then your patients are well. If you're not well, nothing is well, right? We are here to take care of ourselves and then take care of our patients, because if we are not there, our patients don't have us to see. So please, even if the fatality rate is way lower than it used to be before, it's not zero. That's the answer. Next slide. Sorry, next question if there's any. Manohar, do we have any other questions?
No, sir, we don't have any other question. Whatever questions are there, I will present. And sir, thank you very much for in a detailed explanation of flu management. The current challenges are available. I am I'm quite confident that all the attendees must have got a valuable information which will be useful to them in their day-to-day clinical practice. And with this webinar, definitely we can make differences in and improve the quality of life of the patients who are suffering from the influenza. Thank you so much to all the delegates who attended the webinar, as well as Dr. Sitesh Roy. Thank you so much, sir, for sharing your valuable time as well as experience while taking this.
Thanks, Manohar, and thanks to Hetero Healthcare for organizing these webinars. I think they are timely, they are necessary. The message to people of taking respiratory protection, because we are going into the vacation months, people are going to be traveling, air travel, road travel, train travel, high density conglomeration in places of people during vacations and travel and all the other trips that they take. Wear your masks, wear your masks, wear your masks. Very, very important. Take all the precautions you took before. Stay safe and stay healthy. Thank you very much. Have a good night.
Thank you, sir.